Celia.
Hello, good morning.
Hi, good morning. Sylvia, hi. Can you try to use your micro?
Now, thank you.
Okay. And your camera,
Well, the camera doesn't matter, yes, but at least
okay.
to communicate with you.
Okay.
Just to guarantee that the speakers, yes, can use the camera and the micro. Athanasios, can you check that with the speakers that you know
Yes, yes.
who they are?
Mr. Lalas and Mr. Anastasiadis are already here.
Yes.
Can they confirm that they can use their camera and their micro and also share their, do they have the option to share their presentation? I might have to
The
turn off
Mr.
mine
Sava says that his mic is disabled, sorry. No.
on the chat.
From my side, hello, good morning to everyone. I think I'm okay with camera, mic, and sharing.
Okay,
Thank you,
I
Antonio.
have just sent you an updated presentation of yours, if you received it.
Today or yesterday?
Today, just
Let me check,
half an
yes.
hour ago. It's the same presentation. We actually did some minor graphic changes. So if you can use this, we would appreciate it.
Okay, I think this is the one. Okay, the one I have open. Yes.
Antonio's just a minor, design changes we have made, yes, to use the proper template. That was the only thing. Yes, the rest is exactly what you have shared. Okay?
Yes, I checked. It was about some fonts, etc. So
That's it. Fonts and colors and those things. Just that.
Yeah, yeah.
Okay.
You
Mr.
missed the last
Anastasiadis?
slide, but I fixed it. Don't worry.
Okay,
Really?
thank
Thank
you.
you.
Mr. Anastasiadis, you should be okay now.
Now,
Yes, thank you. Good morning. Good morning.
Good morning.
good
Good morning.
morning.
Let me ask,
Sylvia, let
of
me also update your
course, let
camera.
me ask you that I can use my file for presentation, not the one I sent you. Okay.
But
Okay.
is it the same one?
Of course, of course.
Perfect. Yes, just
Okay,
to
no
because we are
problem.
going to upload it to our CCF members area. So just for that.
If it is possible to convert it to PDF, it would
Yeah, for
be
sure.
more appropriate.
We
Thank you.
we will. Don't worry.
Okay.
Thank you.
In any cases, if you did any changes, you can send it to me after the end of the webinar.
No, there are no changes.
Okay. Okay, so everybody is able to share their presentation. That's okay. And we are still waiting for Anna to join.
Athanasios, Anna says that she's also connected, but she can't connect the microphone and the camera also. Okay. She has sent an email.
Yes, yes.
Have you got it?
I've seen it now, but let me see. Anna.
I can't see. Here is Ana Muñoz Ferre. Yes, it is
Oh.
connected. Yes, she's connected.
Hi.
Anna, can you hear us?
There you are. Okay.
Yeah, I've always been here for the last 15 minutes.
Thank you very much.
But I couldn't say anything. Sorry.
Okay, now it's okay.
Okay.
Although
Thank
I
you.
added you all as coordinators of this webinar, I don't know why this happens. Yeah,
It's fine. Thanks.
it's a pleasure to have all
Another
of
thing
you
that I don't
here.
have the option. So I don't have the option to share because it says only meeting organizers and presenters can share.
Really?
Yeah, I'm getting that. So I
Because
don't know if
the other two presenters can present. Because maybe because I have my own at the moment.
Oh, okay. Well,
Check it, Athanasios, just in
I
case.
I will close
Yeah,
mine so
let's
you
check.
can check it. Please, Anna.
no, it says only meeting organizers and presenters can share. Is there any option to make me?
This is exactly
now.
what
Oh, now,
I
yes.
see.
I
Now,
did
yeah.
a presenter.
Now it works.
Okay,
Perfect, thank
I
you.
just need to be a presenter also.
I was just testing.
So, Mr. Anastasiadis, okay. And let me check. Mr. Lalas.
Okay, now I can share. Thank you.
Okay. So, according to my watch, it's 12 o'clock. Welcome all. We will have to wait a couple more minutes in order for all the participants to have the ability to join our today's webinar. For those who joined now, we are still waiting 2 more minutes and we are going to start our webinar. Thank you. Okay, so hello everyone and welcome. Thank you for joining us today on our webinar that deals with digital skills for usability to enhance digital literacy among healthcare providers and caregivers for a better service delivery and patient engagement. My name is Athanasios Politis, and I'm the director of the Directorate for Lifelong Learning and International Programs in the PAN, which is a Greek Hellenic network of cities. And I am honored to be the facilitator of this webinar today. Before we start, I would like to let you know that everybody is muted. Of course, you can post your question or your comments, remarks, etc. in the chat. And be aware that the webinar is being recorded. Over the next hour, we'll be exploring today's topic, and we will talk about digital skills, digital literacy, digital tools, and much more. We are very excited to have with us today 3 highly experienced scientists and professionals that will help us learn and understand more regarding today's topic. According to how the agenda is structured, I would like to welcome and thank firstly Mr. Dr. Savas Anastasiadis, which is a laboratory teaching staff at Lab of Medical Physics and Digital Innovation in Aristotelian University of Thessaloniki. Then Mr. Antonios Lalas, who is an electrical and computer engineer, PhD postdoctoral research associate at CERT, ITI. And last but not least, Mrs. Anna Munoz Fare, apologies for my pronunciation, which is the co-founder and CEO at Fundo Health. So thank you very much, all of you, for being here with us today. So why we are here? The reason why we are here today is ComfortAID's project. ComfortAID's project, excuse me, the official title is Prediction, Monitoring and Personalized Recommendations for Prevention and Relief of Dementia and Frailty. It's a highly promised European project funded by the European Union. It has 39 partners in its consortium, coming from 12 European countries. It has 12 universities, 2 big industries, 10 social, small, medium enterprises, 7 healthcare actors, 4 SSH and legal organization, and finally 4 social multipliers and networks in its consortium. It has a budget of 17.5 million and a total duration of 4 years. Our objective in this project is to generally improve the longevity and quality of life for individuals with dementia and frailty, to address and evaluate complex challenges of aging, dementia, and frailty by combining clinical expertise, technological innovation, and social activation. We aim, moreover, to enhance empowerment and self-management through improved education and digital literacy, like the webinar we are doing today. Finally, we aim to establish a pan-European person-centric framework that fosters prevention and intervention strategies towards facilitating effective lifestyle and behavioral changes. We believe that collaboration is the key that brings together knowledge and passion to transform challenges into solutions. And here is where the ComfortAids Community Forum comes into play. What is the CCF, as we call it? It's a dynamic collaborative network. It's a space to address challenges and share knowledge. It's a means to give continuity to the project after its end. But also, it's a venue for regular engagement, bringing together partners and stakeholders at the same time. The objectives of the CCF, or ComfortAids Community Forum, is to ensure continuity and sustainability. We aim to enhance care quality and accessibility, to support, inform the decision making, and finally, to expand awareness and engagement. Who are the members of the CCF? Apart from the partners that consist our project consortium, members can be all the end users, patients, health and care policymakers, patient advocacy groups, digital health clusters, health tech companies and SMEs, researchers, professionals, health professionals and caregivers, and health and care providers. If you want to learn more, you can join our project website and learn and visit our dedicated project web page that we have for the ComfortAids Community Forum. You can become a member today if you haven't done so, and you can track and see our future activities and attend also our next webinars and foreseen tasks. We, as the PAN today, with the support of our RCCN, we are the facilitators of the second thematic area, the one that we are implementing the webinar today. The second thematic area deals with the skills to facilitate the service delivery models, and it's focused on the factors that favor the effective implementation of service delivery models. The first webinar is happening today, and we are very happy for that. The second webinar is envisaged to happen at the last quarter of this year, and then third one and last for this thematic area is foreseen to take place in the first quarter of 2026. The topics would be, for the second, training and development, and for the last webinar, the third one, will be support and available resources. Having set the framework of our project and our ComfortAids Community Forum, let's talk about technology. So much now can and it is done using a digital platform nowadays, like communication, finding information, shopping, monitoring our health, and even solving problems are just some of the activities which are increasingly facilitated by digital tools. This is why our digital capabilities, like skills and understanding, will help us live, learn, and work in a digital society are so important. As technology is constantly changing, it's necessary to reflect and update on our own digital capabilities. In a sentence, we could say that digital skills is the ability somehow to effectively use the technology. So, digital skills are crucial for enhancing digital literacy and enabling individuals to thrive into the digital world nowadays. Because digital literacy involves not only using digital tools, but also understanding how to assess, evaluate, communicate, and create information using technology, all while navigating the digital landscape safely and responsibly. And what about usability? Usability in digital tools nowadays refers to how easily and effectively users can learn, use, and achieve their goals with a product or a service. So it's a crucial aspect of user experience that encompasses learnability, efficiency, memorability, error prevention, and user satisfaction. Good usability ensures users can navigate a website, an application, or other digital interface with ease, accomplishing their tasks without frustration. Having said that, I would like to thank you once more, all of you, the speakers and the attendees, for your participation. And I would like to move forward and call Mr. Dr. Savas Anastasiadis to make his first presentation. I would suggest and I would encourage you to write your questions on the chat. So after we finish all the presentations from the speakers, we will have time to address them and answer them. Thank you very much for your attention.
Yes, hello. This is Savas Anastasiadis. I'm a laboratory teaching staff at the Lab of Medical Physics and Digital Innovation in Aristotle University of Thessaloniki Medical School. Today I'm going to present you the joint master's program that we have established with two other universities, one from Portugal and one from Finland. Let me share my presentation.
Mr. Anastasiadis, excuse me for the intervention. If you can talk a bit louder because we cannot hear you very well. Thank you.
Okay.
Perfect.
Is it better now?
Perfect. Thank you.
Thank you. So, I hope you can see my screen now.
Yes.
Okay, thank you. As I was saying, I'm gonna present you the postgraduate joint master's program that we have established with two other universities, one from Finland, the Laurea, and one from Portugal, ISCTE. The name of the program is a Master of Managing Digital Transformation in the Health Sector, and the director from Aristotle University side is Professor Panagiotis Bamidis, which also the director of Lab of Medical Physics and Digital Innovation. The Managed It Master's program was designed to address the need to adapt to a repeat technological change, take advantage of digitalization of services, foster enhanced patient care, and interdisciplinary collaboration. Digital transformation has become critical in healthcare for several reasons. Rapid technological advancements are creating new diagnostic and treatment possibilities. Enhanced patient care through data-driven insight is improving outcomes, efficiency gains, and cost savings allow organizations to allocate resources more effectively. At the same time, global health challenges demand robust digital tools, while data security and privacy must be safeguarded. Finally, interdisciplinary collaboration accelerates innovation by bringing together clinicians, engineers, policymakers, and business experts. Between May 2023 and May 2024, which has been announced as the European Year of Skills, focuses on addressing skill gaps across the EU, particularly in digital and green technology, to bolster the EU's overarching skill strategy. The European Health and Digital Executive Agency, the HADEA, oversees this initiative through the Digital Europe program, an EU funding scheme dedicated to bringing cutting-edge digital solutions to businesses, citizens, and public administrations. Our project is funded by HADEA under the Digital Europe program with a timeline from 1st of January 2023 to 31st of December 2026. The managed initiative is especially designed to create a new master's curriculum. Its goal is to equip healthcare professionals with the competencies needed to conceptualize, develop, and implement digital skills and digital health services effectively. Our consortium brings together leading academic and industry partners like East University, Laurea University, Aristotle University. Here I would like to mention that in the beginning there was a fourth institution in the consortium, the Gustave Eiffel University from France, but they drop out uh, their for their reasons, and the program continues with the three first universities. Other partners are Instituto de Telecomunicações, YMOB from Portugal, Clean Power from Finland, and Moody Consulting also from Portugal. The Managed Masters program addresses the unique challenges of managing digital transformation in healthcare. It upskills graduates from health, business, and administration and ICT backgrounds. Emphasis is placed on interdisciplinary collaboration and partnership within a dynamic learning ecosystem. The joint master's degree is delivered by three European institutions, the three mentioned before, the Aristotle University, Laurea, and ISCTE from Portugal. The main goal of Managed are to enhance digital literacy among healthcare professionals, optimize patient-centered care through innovative digital tools, foster continuous innovation in healthcare technology, ensure compliance with regulatory and ethical standards, enable lifelong learning pathways, drive organizational change in healthcare systems, and of course, achieve global relevance by integrating European best practices. Apologies for any noises that might come through my mic. There are some construction works here in our office nearby, so apologies for that. To inform our curriculum, we conducted a 2023 study on social, economic, and technological trends in the health sector. This work included a desk review, focus group with digital health expert and patient associates, and in-depth interviews with key stakeholders across 4 countries, because in that time our partners from France were also participating in all those uh, reviews and searches. The insights gathered from the basis of our skills needs forecasting. The industry connection that we are trying to accommodate will allow students to develop research projects that contribute to the digital transition process of the health sector. Mutual engagement to develop communities of practice and the culture of interdisciplinary co-creation, and connect to partners RIS3 networks. We integrate research and industry through decades of expertise in healthcare and digital transformation, strong ties with global research lab and industry leaders, commitment to real-world application via annual summer school and industry bootcamps, direct students engagement, and collaborative projects address live healthcare challenges. Here you can see the ecosystem that we have built up with Greek stakeholders. Our ecosystem mapping in Greece identifies 4 categories of stakeholders: the partners, the active member, the passive member, and the potentially members. The structured network enables rich collaboration opportunities, ensuring students and faculty can draw on a wide range of expertise for projects, internships, and research. The program spans 3 semesters, each worth 30 ECTS, with up to 240 students intake per year. Semesters 1 and 2 combine compulsory and elective courses, while the third semester is dedicated to the master's thesis. The curriculum is accredited in Finland and Portugal, and by the end of 2024, actually 14th of December 2024, we got accredited in Greece also. As of September 2024, that was the first cohort, 178 students were enrolled, while right now we have completed the selection of the second cohort that will consist of about 220 students from all over Europe. Let me clarify that the program is right for the first two cohorts is financed by the European Union, and all students will be participating, will be enrolled with no fees, but from the third cohort and so on will be there will be fees for our program. Upon completing the program, students will be able to develop advanced data science and interoperability skills for health system, lead digital transformation initiatives within healthcare organizations, ensure data security and privacy measures, and of course, innovate in healthcare technology and management. Our curricular structure is co-built by students selecting from a broad portfolio of sectorial and societal and digital units. Here you can see our structure of the first semester in your left, then second semester in your right. In both semesters, there are three mandatories and two optional from the two branch, the interoperability branch and the data science branch. These are the two branches that every student has to choose to complete the master. As you can see, our curriculum isn't one size fits all program. Instead, students actively co-build their learning path by selecting courses from three distinct portfolios: sectorial, societal, and digital. This flexibility empowers each learner to shape their studies around personal interest and career ambitions. By drawing on this broad array of units, every student can tailor their trajectory towards one of two specialized certifications. In practice, this means you will be graduated not only with deep digital health expertise, but also with a personalized profile that aligns perfectly with your professional goals. We adopt a triological learning and pedagogical model based on modified framework by Pavola and Hakainen work. Especially work package 3 focuses on code design and capacity building, training our teaching staff to identify and implement pedagogical methods that foster interdisciplinary international collaboration among student groups. That was my presentation. Thank you very much for your attention, and I welcome your question and looking forward to discuss any issue further. Thank you.
Thank you very much, Mr. Anastasiadis, for your detailed presentation in what you're doing regarding the master, this master funded by the European Union in your university, regarding the digital transformation, which is critical in healthcare, as you mentioned, and all these upskilling procedure of the graduates in order to get those competencies needed to develop the digital skills within this sector. So thank you once more, and I would like to welcome once more Mr. Antonios Lalas for his presentation regarding telehealth, electronic health records, and other digital tools and platforms. Thank you very much.
Thank you. Good morning to everyone. I'm happy to be here with you. So can you see my screen? Full screen? It is okay?
Now, yes.
Yes,
Okay,
yes.
perfect. So we can start. So the topic of my presentation is the digital platforms, tools, solutions like assistive technologies, telehealth, and electronic health record. So we will get an overview to understand the dementia and frailty, the challenges in managing care, the digital technology and solutions, and of course, electronic health records. And we will discuss about the digital skills and user acceptance that is required, along with the limitations and the ethical challenges that accompany them. So first of all, dementia and frailty. What it is? Dementia is the progressive decline in cognitive function affecting memory, thinking, and behavior. Frailty, on the other hand, is the clinical syndrome marked by reduced strength, endurance, and psychological function, increasing vulnerability. That means we can see the numbers that about more than 130 million people will be living with dementia by 2050. And 68% will be in low and middle income countries. That means this is considered one of the major health issues of the next decades, along with frailty that also introduces a significant burden in healthcare. What are the challenges associated with them? First of all, complex and multifactorial symptoms that require multidisciplinary care. There is a difficulty in monitoring the changes in cognition and physical function in real time. There is some poor communication and data sharing among the healthcare providers. And also there is high risk of falls, of medication errors, and hospital readmissions. And finally, there is the caregiver burden and the lack of continuous support. We can see that 66% say that caregiving interferes with their ability to take care of themselves, but also to take care their daily activities. Similar challenges also are posed for dementia. We can see that 1.4 million people are estimated to be living with dementia in 2040. There is a significant burden on the healthcare system, a significant burden on the people themselves, and also some investments are required to address these circumstances. In order to, let's say, provide a solution, we should adopt the digital technologies and the different solutions along with them. First of all, what it is. Digital tools enable continuous remote and monitoring of the health and behavior. They can facilitate timely intervention and personalized care plans, but also they can improve communication between the patients, the caregivers, and the providers. Also, they can enhance the patient independence and safety, increase their self-confidence as well, help optimize healthcare resources and reduce the associated costs. And of course, successful use depends on users' digital skills and acceptance, which is very important to be carefully supported. We can see a variety of the different, let's say, domains that the digital health can drive innovation. These domains are covering the discovering of new medicines, the developing of medicines together with patients, but also the making and distributing of the medicine itself. But more important, they can support the medicine in use, and they can provide also monitoring of the medicine and patient support. These two aspects are more, let's say, supported by a variety of digital technologies and solutions that have been developed, let's say, per different kind of disease, but also per different kind of users. and they can provide a significant support in the different aspects of daily activities for all end users, either they are patients or even their doctors. So, what are digital health platforms and how they can change the medicine? These platforms can be considered as integrated systems that combine hardware, software, but also data analytics and modern artificial intelligence these days. These consist of different categories. They can be assistive technologies for the end users. They can be telehealth applications, but also they can be electronic health records that can facilitate the whole procedure from the backend. Some examples of assistive technologies. For example, we can have some video surveillance camera, some automated pill dispenser, wearable GPS tracking devices, sensors, a mat with alarm, a smart cane, or even digital calendar and wireless earbuds or other medical devices. What about telehealth? Telehealth, let's say it's the health delivery that uses digital communication tools. That means it includes video consultations, remote monitoring, and virtual therapy. Also, it enables care without travel, and also critical. It is critical during pandemics or for immobile patients. There is a variety of benefits, easy access to specialists regardless of location, frequent monitoring without hospital visits, supports of caregivers with education and counseling remotely, but also it reduces exposure to infections. And there is also a variety of use cases that can be really helpful. Remote cognitive assessments and mental health checks, virtual physical therapy and rehabilitation, remote monitoring of vitals like blood pressure, oxygen saturation, etc., and teleconsultations for medication management and care planning. We can see now a variety of assistive technologies that can be somehow interconnected with telehealth, since there is the limits between them are not so discrete sometimes. We can see here an example of empathic virtual coach for health and workability promotion. It is based on AR technology as a remote collaboration tool and provides digital phenotyping as well. These solutions was developed in the Age at Work project and provide some virtual assistant through the mobile app, but also through even a computer. Another solution developed under the DM4All project was about treating diabetes, providing self-management of diabetes, but also remote patient monitoring. So here we have developed a personalized guidance platform, let's say a virtual coach, along with a prediction engine about the different conditions of diabetes management. So we have a shared care plan, personalized content awareness and visualization, along with decision support system, treatment adherence and behavior monitoring. Another solution was to combine the shared digital phenotyping tool, the virtual supermarket test, and the line tracker tools. All these you can see some pictures of the applications here. To collect and fuse data and to detect markers of patients worsening their health status, for example, cognitive decline and depression. So these solutions have been tested and developed under the Alameda project. Another approach is the AI virtual assistant, which is actually a component with automatic speech recognition. It provides natural language processing capabilities and understanding, advanced dialogue management support, self-reading AI-based platform, and also text-to-speech functionality and flexible integration. This virtual assistant can be provided in different conditions. For example, we can see the virtual assistant in Meyerco's project that was aiming to help patients with asthma and COPD. Also in chronic plus disease to manage another kind of condition. There is this flexibility and can be very helpful for helping people. Another solution is the Coral solution. It is aimed to provide a comprehensive approach to manage and empower health failure. So we developed a web app, mobile app, but also different kind of modules, hypertension, risk prediction, circuit plant, and of course, the AI virtual assistant has been utilized here as well. So it's a complete platform for heart failure monitoring. Of course, we have under the project Take a Breath, the inhaler users training for asthma and COPD patients, providing interactive instructions, live image analysis, and also a virtual avatar to facilitate the training of the patients. Here is another approach of, let's say, usability and digital skills. We do not monitor anymore. We provide training to the patient, but also to the caregiver. Another solution under the Safe project was a smart gardener hardware solution for indoor localization with Bluetooth beacons, and this aims to provide indoor activity partners for friendly prediction. Here we had virtual reality and augmented reality games, but also visual analytics methods for monitoring and analyzing data for predicting frailty. So we presented some examples of different kinds of solutions, assistive technologies, along with telehealth monitoring combined together. However, in order to work, we need also the electronic health records to have a common base of data. So electronic health records is actually a digital version of patient's medical history and care information. It includes diagnosis, medications, test results, and care plans, and is also accessible to authorized clinicians across the care settings. There are several benefits, centralizes patient data for continuity of care, reduces duplication of tests and medication errors, facilitates care coordination between providers, caregivers, and patients, and also enables data-driven decision-making and outcome tracking. Different challenges also occur. Lack of interoperability among different systems, concerns about data privacy, cybersecurity, usability challenges for clinicians and older patients, but also need for training and support in the different systems. So we need the digital skills and also we need the user acceptance. By talking about digital skills, this affects the end users, the caregivers, but also the doctors. That means they need basic digital literacy, an understanding of device functions, an ability to interact with the telehealth platforms, but also privacy awareness and, of course, training. On the other hand, we need to increase the user acceptance. That means we need to provide usability testing, to provide questions and surveys, interviews and focus groups to increase, but also to provide monitoring engagement and iterative design. These groups are the end user, of course, along with doctors that facilitate these user acceptance activities. And finally, some limitations and ethical challenges. Of course, we all understand that digital literacy is still an issue, especially for older people. This is something that has to be treated with special care to provide training and hopefully as we progress, this will be reduced gradually. On the other hand, privacy concerns are very important. Which data should be shared and by whom, who has access, etc. All this has to be discussed and resolved quite quickly so that everyone will be reassured that their data are safe. And there is also the ethical use of AI. AI is a hot topic of these days. Everything will run with AI in the next years, if not already. So how we are going to use it? Is it ethical? This is something that has to be resolved as well. And finally, the user-centered design. All the discussions we had, all the solutions we provided has to take into account the user because it is for the user, it is for the patient, for the doctor. So this iterative design and feedback is necessary in all activities and aspects to make sure that all the challenges will be addressed effectively. So thank you very much for your attention. I'm open for any questions and of course for any collaboration on the topic. Thank you very much.
Thank you very much, Mr. Lalas, for your comprehensive presentation regarding digital health platforms, telehealth, electronic health records, the digital skills and the usability that we are envisaged to have on all those. I hope that the attendees have questions. They can write it once more in the chat, and after the end we can come back to see them. Thank you once more, Mr. Lalas. Now I would like to welcome on the floor Mrs. Ana Munoz Fare. Excuse me again once more for my pronunciation. She will present us their Punto Health application. Thank you. The floor is yours.
Hi. Thanks so much. Nice meeting you. I'll share my screen. Can you see my screen?
Yes, we can.
Yeah, just fine.
Great. Yeah, so I feel like the other two presentations were great to kind of give the context of what we're building and why. So just a quick intro. Punto Health is a digital health startup. We're based in London and Barcelona, and we're basically building an AI platform to help with management of cognitive impairment, dementia, and also entering senior care in general. And our vision, which I think is very aligned with Comfort Age, is a world where everyone, regardless of how old they are or any cognitive challenges, can live a vibrant and fulfilling life, which sounds really simple, but as you all know, it's not. So I thought that for this presentation, I would focus on how we've built our product. It's very aligned with digital skills, usability, and everyone that everything's been talking about. And I wanted to start with how a product development cycle is and how you usually start with ideation. So what are the needs, what are the challenges for our users? Then you move into the concept. So what sort of product would be ideal to solve those challenges? Then you actually need to understand who will pay for it and who will use it, because sometimes we have great ideas, but then if they are not adopted, they sadly die. Then we move into testing and prototyping. So actually building the product and making sure that people can actually use it. And this is where usability comes in. Then obviously improvement and refinement. So based on this testing and prototyping, you improve the product. And then finally you launch and the product is live in the real world. And this is a constant circle. So you always go back to improving and refining constantly. And the other key thing, at least for us, has been that patients, carers, and clinicians have to be involved since day one because they help you in each of these stages. So I'll start with the problem. As you know, I'll go really quickly. Dementia is a problem that concerns most of us. One in two of us will be affected as a patient or a carer. And if it's not us, it's our friends or neighbors. And the cases estimated in 2030 are 78 million in the world, 70% are Alzheimer's, but there's other types of dementia that are also really challenging, and we also want to take them into account. And the other big thing with dementia is that half of the cost and care happens at home, so by informal carers. Most of them are women, daughters or wives, so they are a really big group for us because in this case, if you're building a solution in the dementia space and you don't include carers, the solution will not be used. So we did a lot of user research to properly understand the different challenges. And basically the conclusion, as you know, is that dementia care is completely broken. And there's three groups. So first, it's really exhausting for families. More than 70% have extremely high levels of stress and anxiety. They do everything, they improvise, they try to do the best they can, but they're really afraid. There's extreme high levels of guilt. Then it's really frustrating for clinicians because obviously clinicians want to give the best care they can, but they just don't have the tools or the infrastructure to do so. And 2 and 3 would actually love to prescribe tech to the mentioned MCI patients, but they just don't have those tools. And finally, it's failing patients. So as you know, it's really hard to get a diagnosis, but when you get a diagnosis, more than 65% feel that they don't have any sort of personalized, consistent support. So basically today's dementia is really slow to diagnose, really hard to access, and nearly impossible to manage at home. And we are replacing this with continuous personalized support for every patient every day. But we need to understand where this fits in, right? So if we look at the care journey of a patient, so it starts with, do I have, should I get checked or not? And they have an initial assessment in primary care, get referred to a memory service. If there's a diagnosis of dementia, that's when the treatment starts, which you would think like, great, but not really, because as you know, there's no cure. So it's a combination of pharmacological, non-pharmacological treatment. And the non-pharmacological treatment that has been approved and used for years is cognitive stimulation, but most of it is paper-based or one-off sessions that people can go to every now and then, but it's for sure not continuous and not daily. And then support for carers happens usually in the community. And when they need to find information, it's usually Google, forums, Reddit, Facebook. So there isn't a proper source or place for them to seek this personalized support. And they get reviewed like once a year. So then our concept was, okay, we need to help with this entire journey. And we want to help with this first detection side, but mainly after diagnosis, we want to, or we have two main pillars. The first one is personalized treatment and support. And the second one is improved coordination and monitoring with the providers. We need to cover all stages from MCI to advanced dementia, because as you know, this is a condition that's very progressive. It's not black or white. You just don't have Alzheimer's today and you didn't yesterday. So it's really important to kind of be in from the beginning in this journey. And the solution that we came up with is an integrated platform that can help from early detection to daily care and coordination all in one. And we have two main products, Punto Care, which will be the focus of this talk, which is a companion app for daily support and care plans for both patients and carers. And Punto Test, which is a speech-based digital biomarker for cognitive assessment. This has been co-developed with at the Alzheimer's Center, which is part of ComfortAge, but I will not get into Punto Test in this call because it's more straightforward. We'll focus on Punto Care. So what is Punto Care? Punto Care is to provide continuous support for patients and carers, and we have three main features that help with the three main challenges we identified. The first one is support. So we have a lot of clinically validated resources that give tips, answers, information about anything you can imagine. So, for example, for carers, things around daily challenges of hygiene, like my dad doesn't want to shower. What can I do to help him shower? Or my mom is eating too much or not enough. Or how to deal with behavioral symptoms. If your dad is having a hallucination, how do you deal with that? And this all fits into an AI assistant, which is has the conversational human aspect, but it's restricted to this content so that we make sure that it only replies based on the curated information that we have. Then we have the daily care plans. So this is a set of every day they get a mission, and it's a set of cognitive stimulation exercises, physical exercise, nutrition, mindfulness exercises. It's all gamified so that they actually want to do it, because a lot of times these patients say, clinicians give us homework, but they're boring, and I don't really want to do them. So we've made it fun, and we've also made it adaptive to the level of the person. So if someone, for example, has Alzheimer's and their memory is affected, the memory games are easier for them. So we do it behind the scenes. We don't tell them because otherwise it would be frustrating. But for example, if the user is someone in their early 60s with mild cognitive impairment, they can still be independent, self-managed. So then they might be on the harder level. And then finally, we have a symptom registry, which is really useful to adjust medication. This was a feature request from some of the clinicians we work with, because they want a summary of what's been happening to then decide whether medication, even the time of the day or the dose changes according to cognitive and behavioral symptoms. So then the question that we always get asked is, will they use it? Because we're obviously dealing with the elderly, right? So what we've done from the start is follow the accessibility guidelines. So basically adjustable font size, super simple and minimalist design, necessary elements only, touch areas so that we make sure that they're big enough for them to touch. It's for a smartphone and tablet. So trying to at least make it as easy as possible for them. But the key always, as you know, is to involve all of these patients, carers, clinicians from the start. So we've been really big on the clinical depth on our basis. So we've partnered with key providers and clinics in Spain and the UK. Our main partner, as you know, is at the Alzheimer's Center, but we're also now live in the NHS in the UK, and then with different public healthcare providers and private in Spain. So everything has been co-designed with clinicians. We involve them with every decision. So the design of Punto Care has also been accepted into posters at the European and Spanish geriatrics conferences with one of our clinician champions, Dr. Coy. He's a geriatrician, highly involved with everything we do. But then getting into details of how we actually do this. So the AI assistant, which sounds really cool, right? Like clinicians love it, but obviously they always ask, what happens if the person says this, or what happens if the care asks this? Like they really like it, but they want to be very sure that it's trusted. So what we've done is first we've defined our users, like who are they? It could be an active senior, it could be a patient, it could be a carer, it could be the clinician trying to catch it or trick it. So we define our users and the intent, like why are they here? Why are they using this? And once we've done this, we have to define all possible scenarios because you never know what people will ask. So for example, what if someone says, my dad is bleeding? Like, why would someone say this to an AI assistant? We don't know, but we have to cover that. So then we have to cover all of these possible scenarios. Or for example, one of the clinicians that works with us said to us, what if they ask if they can crash their medication because they have problems swallowing? So you can actually crash some pills, but not all of them. So these are examples of things that clinicians tell us because they hear this constantly, these questions. So then we have to create data for all of these possible scenarios, even the crazy ones that you can think of. Then we have to have an evaluation pipeline. So basically, we need to make sure that we know that it's following the correct scenario. So for example, if someone says, my dad is bleeding, is it following the medical emergency flow? If someone is asking about medical advice, is it following the medical advice, which we cannot give? We have to evaluate each of them. Then we do beta testing. So clinicians, internal users, alpha users, collaborators, they all use it and they all try to trick it. So we say to them, like, try to catch it, try to make it fail. So then you can tell us how it failed. And then we go back to the scenarios. And then finally it moves into the real world. So we're being really careful with this system because especially if it's provided by the clinician, people will trust it. So we need to be really, really careful. And then to finish, I wanted to say how we have been implementing and how we've been kind of giving the digital skills and the resources to the teams to then explain to the patients and carers to actually use this. So this is an example of a case that we have in the NHS. This is NHS Oxley's in Southeast London. So how we usually work, we start with a call with the clinician, the one who's interested, and then we explain to them everything we're doing, how it works, and then they ask questions, and we ask them to try it. They try it. If they have any feedback or things that are concerning to them, then we feedback and we make any changes if necessary. Then we have a demo with the wider team. So this includes everyone. So clinicians, so doctors, nurses, social workers, so everyone who will be around the patient and the carer. And then we provide documentation for users. Really simple, how to download and how to navigate the app so that they have it paper-based in case they want to look at it. We have an optional user workshop. This is, for example, if we are launching in a clinic, we can have a workshop where carers and patients can come, and then we do like mission zero with them. So we download, we play the first exercises, and so on. And then we always keep a feedback loop open. So for any like support questions, suggestions that they might have. And then the biggest thing for us has been that we are constantly observing and listening to our users. So we do this through 4 different ways. So the first one are in-person workshops and focus groups. So literally like giving the app to users and watching, observing how they use it. This is Alba, our psychologist who's in Barcelona. And for example, this was a workshop with active seniors. Most of them were women in their 80s. And here she actually observed that even if you show and explain to certain people how to scroll, so the scrolling that all of us know how to do, they can do it, but then a minute later, they will just forget. Then you show them again and they'll forget again. So it doesn't register. Scrolling doesn't register for some of these groups. So we added assistive arrows. So this is one example of observing, like, where do they get stuck? Then we just solve it. Then we also have in-app analytics and metrics. Sim, our product manager, is very big on this. So basically, we can know whether, for example, they clicked something more or less, or whether they never use a specific feature. All of these things, so that we can see what our users are doing. which we can also do with session replay. So session replay is you can actually replay how someone used the app, almost like a video of how they used it. And this has helped us identify, for example, if they have problems with certain buttons or if they just don't understand an exercise or things like this. So also really useful. And then finally, satisfaction and feedback surveys. So we ask in-app, people who've been using it for a month. For example, we ask them how they've been using it, what they like, what they don't like, and so on. And these are like the metrics that we've had. So who are your users? 80% are women. Women tend to be more proactive about their health. And we already knew this or suspected this, but it's even a higher number than we expected. And this includes all groups, active seniors, patients, and caregivers. And nearly half, around 40% of our users are 75 to 85. So yes, seniors can use it, and some of them are using it every day. Then the other thing with metrics is we use the Net Promoter Score, which is a very common question where you ask, would you recommend this to someone in your situation? And 90% said that they would recommend. No one said they wouldn't. Then the average is that they do 3 or 4 care plans a week, so really high adherence, and some of them do it every day. And they do an average of 20 cognitive games a week, with top users doing 90. We have very engaged, some very addicted users. And then our garden, which is like the gamified aspect, they can build their own garden. 1 in 3 have filled it completely, so it's overflown. So now we've seen this. So next week we are releasing a new garden for these users. So yeah, thanks. If you have any questions or are interested in collaborating, let us know.
Thank you very much, Anna, for your comprehensive presentation. I really enjoyed that all clinician carriers, patients are involved from the first day of your application and in everything that you are doing. You talk about the usability, how Punto Care works, the involvement, the workshops that you are doing with the patients, the carers, in order to be a step-by-step process and the gamified aspects of your application. And we really thank you for sharing your insights and the information with us. So moving on, I see on the chat we have some questions for the speakers. If you don't mind, I would encourage also other people if they want to ask something. So let's start from the first. It's a question to Mr. Dr. Savas Anastasiadis. It's understood that the cross-border joint Master of Science is extremely challenging with respect to the administrative aspects, and congratulations for your program. What about the balance between technical knowledge that need to be provided, for example, AI and data knowledge, and healthcare management skills? How this is addressed in your curriculum? Are there specific fields that you prioritize? And finally, what is the target group of your Master of Science, and what is the background of students that apply and participate so far? So, Mr. Anastasiadis, let's start with you, if you want to answer.
Thank you very much for your interesting question. Indeed, our Joint Masters program welcomes a fundamental technical background, but typically all 3 years bachelor holders of 180 CTS are eligible to our program as candidates. Along the selection period, everyone should be given an interview from our selection committee, and there he can describe their background and their expertise. If the candidate is selected and has no technical background can either attend the corresponding courses to get the technical background, or prefer the other branch, the social branch, that is less technical. Now, concerning the eligibility of candidates, as I mentioned, every bachelor holder is eligible, and of course, for the two first cohorts, the only point was that they have to be from EU states. The program is mainly asynchronous and self-paced, and most of our students are professionals who want to get a little bit more in digital transformation processes. Thank you.
Thank you very much, Mr. Anastasiadis. The question before came from George Manias. George Manias is our project coordinator. So moving on to another question from George to Mr. Lalas. How co-creation approaches can enhance the usability of virtual and assistive living applications? These applications focus on end users, thus they should highly align with their needs and characteristics. Is this something that you take into consideration and apply? Please, Mr. Lalas, if you want.
Thank you for the question. So, of course, co-creation is a fundamental aspect when we're talking about usability. By using co-creation methods, we are taking into account the needs of the different users. These, of course, are the patients, but also these can be the doctors. So this approach, building something, an application or a system in general, together with the people that are going to use it, provides several benefits. We identify early enough, apart from the needs, the different problems that may occur during the use of this application. So the technical people, the developers, have the chance, the possibility to address them really early in the development process. By doing so, the usability is highly increased. We can, let's say, provide early enough a solution that can be adopted more easily by the end users when it is released to the general public. And this is very important. So when we're talking about co-creation, there is a variety of methods to do it, the workshops, focus groups, interviews. Some of them I mentioned already when I was talking about user acceptance. We combine them all together, and we are taking this feedback during the development of the application. We apply this feedback, and we use, of course, an iterative approach. This is not a one-way approach, several iterations. And by doing this, we are making sure that we will maximize the usability at the end of the development process. Thank you very much.
Thank you very much, Mr. Lalas, for your answer. Let's move on. Another question from Mr. George Manias is to Mrs. Anna Farre. How the aspects of explainability of the final outcomes and interpretability are incorporated in your application? How challenging is this? You mentioned feedback loops. Are they fed into your model for further improvement, recalibration, etc.? Please, Mrs. Anna Farre.
Yeah, thank you. So it's not an easy answer because it's a hard question or hard implementation to do, but basically just to for people who don't know what explainability means, so when you're working with machine learning AI models, the old school machine learning, you could know why for specific input to a model, you always had the same output. So you could explain why that happened. With generative AI, they are like black box models, so it's really hard to know why, for example, ChatGPT replied in a way or another, and there's teams within these big companies that literally work around explainability. So it's a question that hasn't been answered yet for Gen AI. In our case, given the very special or difficult space that we're in, which is healthcare, what we do is we use a technique which is called a RAG, which is a retrieval augmented generation. And how this works is, imagine you have ChatGPT and you say, okay, I want to use the conversation aspect of ChatGPT because I want it to be human or give me a good interaction. But I want to make sure that it always replies based on my information and only on my information, so that there are no hallucinations. So the way we do this is you basically restrict the model to only reply based on this information. So we basically say, imagine we're saying to ChatGPT, when there's this question, only reply based on this. And if you don't know, say you don't know, or that you cannot answer. So the way that we evaluate that it's doing this is because you can actually, we have like an extensive data set of questions and answers, and we can know whether it replied them correctly or not, and whether they actually come from our content. When it comes to the challenging part, so the medical, so medical emergencies, medical advice, because we cannot provide medical advice, we actually, it goes through a different flow, so it should never answer. It should always say, you should ask a medical professional, or you should call the emergency services if there's an emergency, right? So the way we do this is we just have to create a lot of synthetic conversations, scenarios, even real conversations that we have, and make sure that they go through this flow. So we have metrics. So we say, imagine out of all of the conversations around a medical emergency, how many went through the medical emergency flow? And then so we want that most of them go through this flow, because otherwise they would put patients at risk. And for the ones that don't, then we need to understand, and this has a lot of experimentation, why they didn't. So it's really complex. And the feedback loops, yeah. So basically, there's this thing called human in the loop, where people can give feedback on how the model replied and so on. So with our clinicians, for example, one of the things we want to do is that they can actually test it and then say, yeah, this was a right response, this wasn't, this could have been better, and then you feed that back into the model. But we could have a webinar around this. It's very complex. So yeah, we use this synthetic data first, then real conversations, and then constant real life feedback. So how the model is perceived, what the clinicians worry about, what carers are asking, topics that maybe we didn't even take into account that people are asking. So then we need to include those. So it's very, very iterative. I hope that kind of answered somehow the question.
I see. Thank you, Anna, for your answer. I see Mr. George Mañas is really happy and excited with your answer. Of course, it's a topic that I don't think you can solve it within the context of our webinar. Thank you so much for the presentation once more and your reply. We have another question for you, Anna. How many people have you already involved and are using the solution?
Yeah, so for the co-design, we had like an alpha, we call them beta testers, beta users, and we kept it kind of small because we wanted to have a close relationship with them. So we had around 30 maybe. Then we launched Punto Care, and in that case, we basically gave it to our clinical partners and through workshops that we did with older adults across Barcelona and the UK and so on. And then that led us to like around 100. So currently we have around 100. Some of them have been using it for months, so the retention has been great. But now we are in live basically with some of our clinical partners. So every week we're getting more and more patients. So for example, the pilots are live in the NHS. Every week we get like it depends, but 10 to 20 new patients. And we just started last week with a new public provider in Catalonia next to Barcelona. And they're just giving it to all the patients they have. So in a week, we had like 20 new patients. So this next week will go from, we estimate to get around 1,000 in the next couple of months from all of these clinical partnerships and our active seniors. But I would say that for the co-design, you don't need so many. You need my suggestion or my recommendation is to always think of the different user types you have and have at least like 5 or 10 each. So in our case, active seniors, so people who haven't been diagnosed, but want to use this, then patients, MCI, but also dementia, and then carers. So with your identified user types, you need at least 5 of each group to make sure that you understand their needs, how they use it, and so on.
Thank you very much, Anna, once more. And as I see, there's a question for myself. It's from Diana. White House from Intel. It's a partner from Comfort Aids, and asks me how I see the thematic network cluster developing. If we try to focus on training courses, cluster of projects currently working, implementation applications like Punto Health, etc. And how do you see the future focus on training people to know about usability as a topic area, courses, project, the design and use of applications or other products? Thank you very much, Diana, for your question. To tell you the truth, today I cannot give you a definite answer. Those are also concerns that I have in my mind. It's not something that has to do only from my side, but also we have to involve RCCN into that, as they are the coordinator of this Comfort Aids Community Forum. And also we have to think and link it with the other tangible deliverables and outcomes that we have in terms of our project, like the TED and the TEM. So thank you very much for your question and the idea for the next webinars, how they're going to be implemented. I'll take this into account, and we hope to have soon a concrete answer to give to all of you for our next steps. I hope that I covered you. Moving on, I don't see if there are any other questions. I don't see in the chat. I think that was all. We are according to the timetable of our agenda. Before we close, if you don't have any other questions, or if the speakers don't want to ask each other something or to comment on each other, then I will have some questions for you all, for the participants and our webinar. It's a quick poll. Just give me a second. Okay. Wait a minute to be uploaded. I don't think it's working. I don't know why. For some reason, this doesn't seem to work. There are some questions for you all. Maybe there's a technical issue. I don't think that I can solve it right now. Just give me one more minute. If not, I will have to send to all of you our questions, and please be kind to get your feedback It's very valuable for us in order to assess the webinar and all our activities within the Comfort Age project. So, unfortunately, I don't know why this poll doesn't work at the moment. Apologies for that. So if there are no other questions in the chat, or if you don't want to comment anything else, I would say that we can conclude our first webinar here. Thank you very much again once more. First of all, the speakers for being here and giving us our insights and our information regarding our topic. And moreover, I would like to thank you all, the participants, for being here today. I hope that it was very useful and fruitful for you all. And we are hoping to see you again in our next webinars within the Comfort Age Community Forum framework. Thank you very much, all of you.
Thank you,
Thank you very
Athanasios.
much.
Thanks
Thank
so
you,
much.
everybody.
Thank you.
Thank you.
Bye-bye.